Okay. So actually, if I would like to just do my role here and argue with Dr. Amir, I can use the first half of the slide saying that the diagnosis of pulmonary hypertension relies, according to the definition, on a catheter-measured pressure of more than 25 millimeters of mercury mean. So if you need a catheter to make the diagnosis by the definition, you need to do the catheter anyway. But this is not what I want to argue, actually. I believe that echo is very important, and I believe that catheterization is very important. But the most important is to have an approach to the patient that is comprehensive and includes both the echo and the catheter in a logical way. And this is what I would like to convince you. And this starts with the history taking. So this is maybe not the role here in the debate, but you need to take the history to know if the patient had cyanosis, if he had a murmur when he was a child, because murmurs disappear once the pulmonary pressure goes up. So patients can be born with a shunt lesion, have a murmur as a child, may have heart failure as a child. Then you see them when they are 15 or 18, they don't have a murmur, and sometimes they are not yet blue, and still they may have severe pulmonary hypertension. You need to know if they have exercise limitation, and you need to know when it started. Because if you have a patient who tells you that he has been unable to exercise properly for 15 years, this patient probably doesn't have primary pulmonary hypertension. You have to look elsewhere. So all these things are very, very important before we go into the methods of investigation. And then we have the physical examination. And we cannot overemphasize the role of physical examination. Of course, the most important physical sign would be the differential cyanosis. If we don't measure the O2 saturation in the legs, we will miss an important part of patients with Eisenmenger ductuses and will diagnose them as primary pulmonary hypertension. And I'm not talking fiction. I can tell you about some patients who were diagnosed wrongly, just by not taking the O2 saturation in the legs. And we can, of course, hear a continuous murmur in a patient and know that this patient does not have severe pulmonary hypertension, at least not in that lung segment that produces the murmur. I can just give you an example. This is a girl who had a complex cyanotic heart disease. She had a Waterstone shunt. She was assumed to have severe pulmonary hypertension. She was put being 30-something, on the transplant list. She came to me the first time. I just listened to her chest. I heard a continuous murmur. I realized she couldn't have severe pulmonary hypertension, at least not in the right lung. And here you can see a severe narrowing of the right pulmonary artery. We wouldn't look for it if we didn't have this physical finding. So she was catheterized. She had a completely normal right lung. So it would have been a disaster had she been transplanted. Now, if we have a patient with a duct, people think that echo is a very, very good diagnostic tool. But to see a duct in a patient who is hypertensive and doesn't have a big flow is quite difficult sometimes. All you can see from the suprasternal view is to see something like this. This is the duct. And then you can see a little bit of color flow, and that is all. You will not see anything else in the heart. The heart will look exactly like the one in primary pulmonary hypertension. So if you know that the patient has that differential cyanosis, you will be looking for the duct. You may have a better chance to find it. Now, echocardiography is excellent, and we can look for the I will skip this because I think these things are well known. I think not only a duct, also a sinus venosus defect is sometimes very difficult to diagnose on transthoracic echo. And I would suggest that if Dr. Amir suggested that we do to all patients echo and TEE, it would be a better suggestion, because I think most patients with pulmonary hypertension, if we don't have an obvious diagnosis, we cannot make the diagnosis of primary pulmonary hypertension, idiopathic pulmonary hypertension, before doing a TEE as well. Now, of course, echocardiography is an excellent tool for follow-up. This actually is not a topic of the debate, but of course, I agree that once we have a fully established diagnosis and we want to follow up the patient, echo is an excellent tool. But there are pitfalls in echocardiography. First of all, patients who come early on in their course of disease to have an echocardiogram can get out from the echo lab with a diagnosis of a normal heart. This has happened, and it's terrible, because once they have another echo in 6 months or 8 months, they are going to be much more sick, because many of them initially don't have a TR signal that is good enough, don't have a PI signal, or people don't look at the PI signal, and this can be missed. And you have false positive echocardiograms if people miss pulmonary stenosis, which happens from time to time, or if the patient has a small VSD and the velocity of the VSD transects the beam of the continuous wave Doppler, giving a false positive impression of a high TR gradient and a false diagnosis of pulmonary hypertension. Now, many hyperdynamic conditions cause an elevated TR gradient, an elevated systolic PA pressure, which is still not compatible with the diagnosis of pulmonary hypertension. It's only by cath that we can make sure that the patient has real pulmonary hypertension. So that's also important. If we have a 70 or 80 TR gradient, probably the patient has pulmonary hypertension for sure. But if he has 50, we're not certain. We can miss lesions, as I told you before. And as I said, TTE is often not enough. We need at least to do now a transesophageal study. Now, doing the CAT doesn't mean that we want incidentally to find the diagnosis on the CAT. This, if it happens, it's quite unfortunate. We want to go to the CAT knowing everything that we need to know in advance. And but sometimes you can see here is a CAT going through a patent arterial duct, doing just a right heart cath. And here we have one going into an anomalous pulmonary vein and taking the catheter to the other side. We go through a sinus venosus defect. This happens sometimes if you go to the cath lab without having all the information beforehand. But catheterization, first of all, I don't think that right heart catheterization is a good definition of the procedure. It is a complete hemodynamic assessment of the patient. And these catheterizations should always include a left heart study and a catheter in the LV to make sure that what we are recording as a wedge pressure is a real wedge pressure. If we have a low LV EDP and a high wedge pressure, and the patient doesn't have pulmonary vein stenosis or mitral stenosis, we know that our wedge is not a true wedge. And this happens more often than people would like to believe. And if they don't have an LV catheter, they don't really know. So I don't think that right heart catheterization is something that should be done at all. And we always have to take an extensive set of saturations during the catheterization to avoid missing abnormal shunt lesion. And if we are doing the CAT in patients who have collaterals, we have to be sure that we go deep into the collaterals, especially if the patient has continuous murmurs. I have seen patients diagnosed as severe pulmonary hypertension just because the collaterals weren't catheterized properly. And we have to do the tests, of course. But with the test, we test the resistance. There's no way that echo can give us an accurate estimate of the resistance. And if we don't know the resistance, sometimes the pressure, doing a test, the pressure doesn't fall. It's the cardiac index that goes up, so that the resistance goes down without the pressure going down. So echo is not a good enough tool. And of course, if we are assessing patients with a shunt lesion, we have to see that their resistance goes below 7 Wood units times meter square with a test in order to make them eligible for surgery or catheter closure. In intermediate cases, resistances between 7 and 11, we sometimes should give them medication to lower the pulmonary pressure for several months and repeat the catheterization to see if we did anything better. Patients who have a resistance that is above 12 Wood units times meter square should not be operated on. And sometimes neither echo or CAT can give us the full information, and sometimes we need other modalities. This is a CT scan showing a patient with Eisenmenger syndrome, and only this modality can show us the extensive thrombosis that occurs late in the natural history of disease, when all the major pulmonary arteries are lined with huge thrombi. That is part of the natural history